Oh, that's why. Okay, are there any questions before we start today? So we were talking about volume and pressure, and there is a nice diagram in the online textbook that shows how those two variables are related. So as you decrease the volume, then what you're doing is you're making those molecules occupy a smaller space, and so they are going to exert a greater pressure. And so what is it in your lungs that is changing the volume when you are inhaling and exhaling? Nope. What's changing the volume? The diaphragm, right? And so I have a little animation that shows how the diaphragm moves. And you'll remember that as a muscle, when it is relaxed, it is actually dome-shaped. And when it is contracting, it actually moves down. And so it will change the volume of the lungs. So let's see if I can, oops.
The diaphragm is a thin, dome-shaped layer of muscle and tendon that separates the abdominal cavity from the chest cavity. It gains its shape from its attachments and from the organs that surround it, especially the heart, lungs, and liver. The diaphragm attaches at the costals along the lower rib cage, high in the front of the sternum, and deeply in the back along the spine. The diaphragm also attaches to itself via a central tendon, making the diaphragm one of the unique muscles of the body. The diaphragm uses its central tendon and its attachments as leverage to flatten during inhalation. The expansion of the ribs comes from the resistance of the internal organs to downward movement. As the internal organs are slow to move, the ribs expand to make room for the lungs. While the diaphragm attaches at the bottom of the ribs, its range of motion never reaches that low in the body. As seen from below, we get a sense of the full range of motion of the diaphragm as it would glide over the aorta, the vena cava, the esophagus, and the internal organs. For more information, visit www.3dyoga.com.
Okay. So in yoga class, they actually talk a lot about diaphragmatic breathing and using your diaphragm to breathe more fully. And one of the really interesting things that I have recently discovered about that is that sometimes your diaphragm, like any muscle, can become weak. And so when you ask people to breathe deeply on a regular basis, sometimes they will feel pain. And so that muscle can actually get fatigued and it can actually start to spasm and you can actually kind of get a cramp in your diaphragm. So if you've ever had to breathe deeply for an extended period of time, you might have had that sensation of that muscle being not feeling comfortable, like maybe exhibiting some kind of spasming or pain.
So is it the diaphragm that creates that? So like when you breathe in and your lungs fill, is the diaphragm controlling that, or is your lungs kind of controlling the diaphragm? Does that make sense?
Your diaphragm is controlling it. So there's a nerve that goes to your diaphragm. We'll talk about the neural control, but it controls the diaphragm. When it contracts, it moves down a little bit, as you saw, and that is going to increase the volume, and that's going to create negative pressure, and that is going to cause air to automatically move into the lungs. Okay. And so when the diaphragm relaxes, it moves up. And so shallow breathing might not use the diaphragm that much. It still uses it a little bit, but not to its full extent. And the other thing about inhalation is that we have these muscles that run between the ribs. And so these are called the intercostal muscles. So the intercostal muscles run from one rib to another. And there's actually two different types of intercostal muscles. They are called the external and the internal. And the external intercostals are the ones that are involved in elevating the rib cage and expanding it. So when you take a deep breath, your diaphragm moves down, but your rib cage expands, right? And sometimes that can be painful as well. You can kind of feel pain between the ribs, those intercostal muscles contracting. And then when they relax, that causes the rib cage to go back to normal. Now you can also depress the rib cage and your abdomen even further to get rid of all of the breath. And that is actually the role of the internal intercostals, or the ones that depress the rib cage and actually make it smaller to force all of the air out.
So I'm wondering, so whenever, say you're running, like you just go out, full out run, and then you get like a cramp, is that the diaphragm?
It could be. So it could be the diaphragm, or it could be your intercostal muscles.
Like when you get that sliding?
Yeah, you get those. Yeah, yeah, yeah. Yeah. Okay. So when we talk about the control of ventilation, primarily this is unconscious, right? So it is the brainstem, and specifically the medulla oblongata. So when we look at the brain, the nervous control, we have the medulla oblongata, and this has respiratory centers. Right, so this is part of the brain stem, and we have the respiratory center. That this is autonomic, so it would be part of the peripheral nervous system. And when we talk about respiration, what it is cueing on is primarily blood pH. So it responds to blood pH. And this is due to the fact that when we have a buildup of CO2 in the blood, that is actually going to cause the blood to become more acidic. So CO2 in the blood combines with water, and it produces carbonic acid. So this is called carbonic acid. So what's going to happen is that the CO2 is going to build up, and it's going to decrease the blood pH. Okay. So when you're exercising, for example, and CO2 starts to build up and you cannot breathe enough of it out, what is that going to do is that's going to send a signal to the medulla oblongata that you need to breathe more deeply. And so like after sprinting, for example, that's why you stand and you go, right? That's all the control of the medulla oblongata. Now, of course, we can kind of consciously override this as well, but it's important to realize that this is not actually measuring O2, but it's actually measuring carbon dioxide. But that is also going to be related to oxygen, because as we get rid of CO2, we also take in O2. Okay, so you'll notice that there are other parts of this that also can affect breathing. So for example, here we have actually receptors that are located in the aorta and also in the carotid. So that would be the carotid artery that is delivering blood to the brain. And so those are going to measure the concentration of carbon dioxide and the concentration of oxygen and pH. And then we also have the hypothalamus, which is that fight or flight response, fear, emotions. And so that can actually also cause you to increase your breathing rate. And then the cortical areas of the brain, that's your cerebral cortex. That's the outer part of your brain. That is what is involved in consciously breathing. So you can consciously make yourself hold your breath, right, against your desire to breathe, but you can also make yourself hyperventilate by forcing yourself to breathe deeply. Okay. So in your book, there's a little diagram that shows these responses. And so this just shows the medulla right here. There's also some areas up in the pons. But this just shows that these send signals to those muscles that cause breathing. And so these signals are not going to the lungs per se, but they're actually going to your respiratory muscles. And so they are going to signal the diaphragm and the external intercostal muscles to contract so that you breathe, you inhale. Okay, so we do have the cessation of breathing, which is called apnea. So this is the cessation of breathing. Apnea, or the PNA, that is actually just means breath. So we can talk about apnea. So this is good breath. So good breathing. And then we can also talk about when you breathe excessively. So this would be hyper. Oops, hyper. I hate when that pen does that. Hyperpnea. There we go. And this is excessive breathing. Okay. So apnea has gotten a lot of press recently because we've discovered that as a person gets older, they are more likely to stop breathing while they are sleeping, right? And so this is a problem. And one of the problems is related to sometimes people can have obstructions in their throat. So the muscles can actually collapse the throat, and so that will make them stop breathing. And then they'll like snort and they'll open up their airway. And so they have these periods where they're not breathing. And so this is called obstructive apnea. So this is where the tissues block the airway. And people that have this sometimes snore excessively, right? And they make funny noises when they're sleeping. And that is because they're having a hard time getting air into their lungs. There is another type of apnea, which is called central apnea. And this has to do with the control of the central nervous system, right? So the central nervous system, or the CNS control, is damaged. And so sometimes this happens after, for example, a stroke or other brain trauma. That is more uncommon than the obstructive apnea. And so if a person is overweight, for example, they might have a greater probability of getting obstructive apnea. And I'm not sure why it seems to be more common today than it was in the past, although obesity has increased and is more common today than it was in the past. So maybe that's the correlation there. But how do they treat this? Does anybody know? What's it called? CPAP. What does CPAP stand for? Do you know?
Continuous positive airway pressure.
Yep. Continuous positive airway pressure. So remember that we generally inhale because of negative pressure, right? So this is just like giving them air that forces their airway to stay open while they are sleeping. So they have to be on a machine, right? It's a little mask that they wear that provides constant positive airway just to keep the airway open. And then it generally has a little bit higher oxygen than just the normal air. So they're getting extra oxygen. And so this can actually really change a person's life because apnea can cause all kinds of problems. So it can cause you to be sleepy and fatigued, but it can also cause damage to your heart if it is not getting enough oxygen. And if your brain is not getting enough oxygen, it can essentially lead to some brain damage. And so it makes people difficult to think, and it can lead to all kinds of stuff. And so this is actually kind of a good thing, although I think it probably is a pretty annoying thing to have in your bedroom. Yeah. Maybe they will figure out a better way to do it. Okay. Okay. Okay, so now we're going to talk about the pressure not inside the alveoli and outside, but the pressure between the pleural membranes. And so this is between the pleural membranes. So that's space. And remember that space is filled with fluid, serous fluid, that is produced by the serous membranes, and it creates a friction-free movement of the lungs in that membrane. And so what sometimes can happen is that this pressure can change, and it will actually lead to the lung collapsing. So it needs to be about a -4 millimeters of mercury. So it needs to be lower than the pressure inside the lungs. So that's mm, mercury, and inside the lungs. That's a -4. So that is generally written as like a 756 millimeters of mercury, because if the atmospheric pressure is 760, then that would be -4, right? So this actually keeps the lungs from collapsing, this negative pressure, because the lungs have a lot of elastic connective tissue. They'll want to collapse, and so this actually kind of creates a vacuum that sucks and creates and keeps the lungs from collapsing. So when we see the lungs collapsing, this is called atelectasis. Atelectasis. That's Atelectasis. So this is a collapsed lung. And this collapsed lung is when we get air into that space and it changes the pressure. So this is what is called a pneumothorax, when you get air into that pleural cavity. So pneumo means air and in the thoracic cavity, but it's actually in the pleural cavity. So one way that this can happen is through traumatic injury. So you can have a traumatic pneumothorax. So this would be like a wound from the outside puncturing so like a bullet, for example, can cause the lung to collapse, or a blade, or just being in a car accident, you get something puncturing that membrane, air can get into there. The other type of pneumothorax is called a spontaneous pneumothorax. So this is spontaneous. And so this is caused from air leaking from the lungs into the space. And this is usually due to lung disease like emphysema or COPD, chronic obstructive disease, pulmonary disease. So this is where air leaks out of lung and into space.
This could also be traumatic as well, right? Like if you were to get hit by something, but it's no actual puncture, but it could.
Oh, yeah. So that could be if it
like,
is also leaking in. So spontaneous, maybe if there's no, spontaneous could be if there's no traumatic injury, right? I guess that's true. So the traumatic pneumothorax could also be if you damage the membrane and the lung, then it can leak into space. Have you ever experienced that?
Well, I just know that going through like the EMT program, they just talked a lot about how, and this is kind of going to the medical thing, that traumatic and spontaneous, you have to be very careful how you describe it, because you could go on a patient that's been in a car accident, wearing their seatbelt, get them to the hospital, and all of a sudden they're dying because they can't breathe. It's still traumatic because it's still tore inside, and it still might have messed with like this air sac and stuff filling with fluid. Not so they just learn to puncture or to fill their lungs or whatever, but they talk a lot about trying not to just think of traumatic as just an open wound.
Okay, good. That's a good point.
Just because, traumatic could be that it punctured the lung, punctured the wound, so you're getting air out of the whole cavity.
Right.
Whereas you can still be traumatic and spontaneous.
So you don't have any opening in the body.
That's when you'll see the filling of the belly or other.
Okay.
But just
Thank you.
Curious if it kind of was the same thing.
Yep. I'm sure that those two things are related. So this is a diagram that shows the pressure inside the lungs versus the pressure inside the pleural cavity. And so notice the negative, notice the vacuum that's actually been produced inside of that cavity. And so a lung collapsing would look something like this, right? And so this, what happens is that air gets into this space and it changes the pressure. And so the lung will collapse. So it's no longer a negative pressure. So one way that you can treat this is by putting a tube, right, into that, and you're actually going to get air to, actually it should be in that, not through the lung, but in that cavity. So you can actually get air out of the cavity. So I've heard that it's kind of like a bicycle tube, right? When air comes out, it sounds like psst, right? So air leaves that space, and then it will hopefully seal itself back up and create that negative space. So you can actually see collapsed lungs on a X-ray. Here it's kind of hard to see, but this is normal lung tissue on this side, and this is actually the collapsed lung. So notice how far it can collapse down into. And then we can see the other one. This is actually a CT scan. So then that's taken different, but you can see the collapsed lung versus the normal lung on that side. Okay, so we're going to move on to gas exchange. And when we talk about gas exchange, we're going to talk about respiratory pigments. And the respiratory pigment that we use is called hemoglobin. The unique property of hemoglobin is that it is able to bind reversibly to oxygen. So what that means is it actually behaves differently in different parts of the body, because in some places it picks up oxygen and holds tightly onto it, and in other places it has to get rid of the oxygen to give it up to the tissues. And so that's what's kind of unique about this molecule is that it changes its shape depending upon the environment, and it makes it more likely to either take up oxygen or release oxygen. So that idea of binding reversibly is really important. So we can talk about what is called deoxyhemoglobin. So it is HHB. This is my deoxyhemoglobin. So this is without oxygen. So if I combine oxygen, if I add oxygen to it, I'm going to get oxyhemoglobin. That looks like that, so HbO2. So notice I just made that chemical equation go in two directions, because that's the idea of reversing it. And then we'd also have, to balance it, we'd have a hydrogen ion out there. So this balances it. Now, it's incorrect to think of deoxyhemoglobin or deoxygenated blood as being blue. This is actually, deoxygenated blood is actually a darker red, as composed to a oxy, which is a brighter red. So you can always kind of tell if blood is coming from an artery, is if it is bright, bright, bright red coming out. Okay. The venous blood will be a darker red. The reason why we think it is blue is because it is darker in coloration. We see it as it is, the light is reflected, we see it as blue in the veins, right? So it's just a reflection, looks blue. Oops, blue in the veins. So if we look at the structure of the hemoglobin molecule, the hemoglobin molecule has two globins. So we'll talk about the structure. Two globins, actually four globins. So these are proteins. You might have heard of these proteins before because there is a disease called sickle cell anemia, which is due to a defect in one of the globin proteins. And so with these 4 globins, we have 2 alpha globins, and that is the Greek letter alpha, and we have 2 beta. So the Greek letter beta. So when we talk about sickle cell anemia is a genetic defect in the beta globin molecules that causes the hemoglobin to change shape and causes the red blood cells to sickle under certain circumstances. Okay. Then we have the heme group. So the heme group contains a mineral. And what mineral does the heme contain? Iron. This is actually what oxygen binds to. So there's actually 4 hemes. This contains iron, and it can bind 4 oxygen molecules. And when it picks up one, it actually makes it more likely to pick up more. So we can talk about hemoglobin saturation. So saturation refers to the oxygen binding to the hemoglobin molecule. So if your blood is 100% saturated, then what that means is that all of your hemoglobin molecules are carrying 4 oxygen molecules. If it is 80% saturated, that is really getting low. And that means that fewer of the hemoglobin molecules are fully saturated or carrying all 4 of the oxygen molecules. So you can measure hemoglobin saturation using what is called a pulse oximeter. And you probably have all had these done to you in the doctor's office, perhaps. And this is a little thing that they put on your finger, and they can measure your hemoglobin saturation. And they want it to be above what value? Does anybody know? 90, but 75 is low, considered to be very low, right? So you can, if you are below 75%, then this is hypoxia. So hypoxia means low oxygen, right? And you will probably be cyanotic. What does that mean? Blue. Okay, so cyan is blue. So this means that you'll have a blue tint to your skin. You'll probably be able to see it in the tongue, the gums, your fingernails, your lips sometimes turn blue, right? So cyanotic means that you're hypoxic and you do not have enough oxygen. So again, that would be because of the deoxyhemoglobin, the high levels of deoxyhemoglobin in the tissues. Okay. I'll come back to that in a second. Okay, so this is my red blood cell. And so inside the red blood cell, this would be my hemoglobin molecule. And you'll notice that these are globins. These are proteins that are highly folded. And then these are the heme groups that they are also organic. They contain nitrogen too, but they also have an iron center. So the next thing we're going to talk about is what is referred to as the dissociation of oxygen from hemoglobin. So this is where the oxygen is given up by the hemoglobin molecule, and there are a couple of factors that are influenced by this. Okay, so we can talk about the concentration of oxygen and carbon dioxide in the blood. Now, the concentrations of gases are what are referred to as partial pressures. So this equals the partial pressure of the gas. Right. So the way to designate partial pressure is just with a big P, and then you could either put an O2 or a CO2. So it looks like this, PO2 or PCO2. I want you to just think about those as the concentrations of the gases in solution. So they're in the water, but that's their concentrations.
So is that the PO2, that means partial pressure?
Yes. Yeah, so that means partial pressure of oxygen and partial pressure of CO2. So when we look at the partial pressure of oxygen, it is high at the lungs, but it would be low where tissues are metabolically active. So like in your muscles, your partial pressure is going to decrease, right? And so we can look at a curve, and these are what are referred to as dissociation curves. Okay. So this shows on one axis the oxygen saturation. So this shows how likely oxygen is going to be bound to hemoglobin. So it also shows the affinity of hemoglobin to oxygen, if it's going to grab it or not, or if it's going to release it. So you'll notice that in the lungs, the partial pressure is really high because that is where it is picking up oxygen. And so you'll notice that O2 saturation can be really high in the lungs. But as we move out to the tissues, notice that the partial pressure of oxygen decreases. So here at 40 millimeters of oxygen, millimeters of mercury, the partial pressure of oxygen is going to cause the oxygen to be released so that it can be taken up by the tissues. So one thing that affects this dissociation is PO2. So as we decrease PO2, hemoglobin releases oxygen. Okay. And saturation decreases. Saturation levels decrease. Okay. So this would be like at the tissues. And the reverse would be true, that when hemoglobin goes to the lungs, it's going to not release oxygen, but rather it's going to pick it up. So as you increase PO2, the hemoglobin is going to pick up oxygen and saturation levels are going to increase. Now, the hemoglobin molecule also responds to pH. So as pH decreases, hemoglobin is also going to release oxygen and saturation levels will decrease. Now, what did I just mention that, what is the molecule that influences pH in the body? Carbon dioxide mixes with water and produces acid, right? So this would also relate to an increase in PCO2. Okay. So as you increase, so your metabolically active tissues are producing carbon dioxide, and so they're going to have a lower pH. And so that is also going to lead to the dissociation of oxygen from hemoglobin. The other thing that's kind of interesting is that as you increase temperature, you're also going to get hemoglobin releasing and saturation levels decreasing. And so again, metabolically active tissues like the muscles are going to be warmer, right? And so that's where hemoglobin is going to give up its oxygen to those tissues that are using the most oxygen and producing the most energy. So we can see how these influence it by looking at these curves. This actually has a name. It's called the Bohr shift. So you don't need to know that, but kind of interesting because it just shows how hemoglobin responds to decreasing pH levels. So notice that at partial pressure of 40, for example, if you have the lower pH, hemoglobin is going to be less saturated. Right? So that line at pH 2 means that the hemoglobin is going to be more likely to give up oxygen than if it's a pH 7.6. Notice those are still actually basic, but that is the range of blood on pH. The pH of blood is about 7.45. And then we also have temperature. So as you increase the temperature, right, oxygen is going to be, say, at 80 degrees. No, that's a partial pressure. That's not temperature. Oh, there. Is that? Okay, so let's see. Temperature influences it. So at a partial pressure of 80 and 43 degrees versus 38, right, hemoglobin is going to be less saturated at the higher temperature than at the lower temperature. So the hemoglobin molecule is a globular protein that is really sensitive to variation in what is happening in the tissues, okay? pH, temperature, and concentration of gases. Okay, so let's go back to those partial pressures, because that relates to how the gases move. They diffuse against, or excuse me, they diffuse with their concentration gradients. Okay. So when we look at air, what we are breathing in to our lungs, really interestingly, our atmosphere is primarily made of nitrogen. And the really interesting thing about that is that we do not interact with that nitrogen at all. We cannot get the nitrogen out of the atmosphere. It's in a really stable form. And in fact, the only organisms that can actually get the nitrogen out of the air are bacteria. And those are nitrogen-fixing bacteria. Another interesting thing about nitrogen is that lightning can fix it. So lightning can actually cause nitrogen to come into a form that comes down with the rain and can be taken up by plants and then can be taken up by us. Okay? So even though nitrogen is really abundant, it does not move across our respiratory membrane. So if you look at water, or excuse me, if you look at oxygen, it is about 21% of the atmosphere. So if we look at oxygen, it is about 21%. Now, if our total atmospheric pressure is 760, we would just take 21% of that, right? So 21% times 760. So that's the total atmospheric pressure. So we could say, well, what is that concentration of that? What is the pressure exerted by oxygen alone? And that 21% of 760 is about 160 millimeters of mercury. Okay, so that's where they get those values.
What is the 160 like?
So this is the pressure exerted by oxygen. So this is the total pressure exerted by all the gases in the atmosphere. This is the pressure only exerted by oxygen. That's a great question. The 160. So if we look at how these concentrations affect diffusion, remember that diffusion is a passive process. And so we can look at air that is coming into the lungs, and notice that's at that 160 millimeters of mercury. And then we can look at blood coming into the body. So blood leaving the tissues and entering the lungs is at 40. Right? So 160 millimeters of mercury. So my PO2, right? So this would be air in lungs. And then my partial pressure of the oxygen in the blood is 40 millimeters of mercury. So this is blood, right? So the way that the diffusion is going to occur is it's going to go from a higher concentration to a lower concentration. So this is the diffusion. So it's set up that that's why it's important for the oxygen, the low oxygen to come in, low oxygen blood to come into the lungs, because you have to have these differences in partial pressures in order for diffusion to take place. And remember that that was actually part of that equation, the Fick's law of diffusion, was that partial pressure difference, right? So the difference in the partial pressures, right? So that triangle just means the difference or the change in partial pressures. That would just be 120 millimeters of mercury. So that's pretty high. So the rate of diffusion is going to be high. Now, if we look at CO2, CO2 is going to move the opposite direction. So CO2 coming in to the lungs, right, from the tissues as at 45, you don't need to write this down, but in the air, it's only at 0.3. And so CO2 is going to diffuse in the opposite direction because it has a different concentration between the inside and the outside. So that's what those delta P's and the partial pressures, their significance. If this drops to 0, right, then diffusion isn't going to occur at all. So this is actually why when people have lung disease, we give them air that has higher concentration of oxygen. So by giving them oxygen, that is going to increase diffusion rates, right? It's going to speed up diffusion, right? So supplementing oxygen through air is going to increase diffusion because that difference is going to speed it up. So those are people that have chronic emphysema or COPD, and they have to walk around with their oxygen tanks just so that they can get enough oxygen to be able to function properly. Okay, so we also have to transport not just oxygen. Oh, this is an example of cyanosis. So that would be peripheral cyanosis, where they have low oxygen concentration, low saturation in their peripheral systems. Okay. So we also have an interesting problem, and that is fetal hemoglobin. Because the mother has to pump out the blood to the placenta, and it is well oxygenated when it goes to the placenta. And so we want to ask, how is the hemoglobin going to be able to be transferred from mother to fetus? And so when we look at fetal hemoglobin, it has a higher affinity to oxygen than maternal or adult. Right, so it's going to tend to want to grab it and pick it up. Oxygen has to diffuse across that placenta from the mother's blood to the fetal blood, but the fetal blood will tend to pick it up even when it is not that concentrated. It'll tend to pick it up. Okay. So the thing about the fetal hemoglobin is that it is actually 2 alpha globins and 2 gamma globins. So there is no beta globin in fetal hemoglobin. So that means that the genes that produce fetal hemoglobin are different than the genes that produce adult hemoglobin. So gene regulation, the genes that turn on are going to, upon birth, turn on the production of adult hemoglobin. So just if we look at the diagram of this, we'll see that the adult hemoglobin, right, after a partial pressure of, let's say, maybe 75, the adult hemoglobin is going to start to release the the oxygen, and then the fetal hemoglobin is going to pick it up. So notice that it is going to hold on to it for much longer. So even at the tissue level, the fetal hemoglobin tends to be more saturated than the adult hemoglobin. Okay. So something really interesting happens upon birth, and this is the idea that fetal hemoglobin is rapidly destroyed at birth. So hemoglobin, the iron can be stored in the liver, but one of the things that has to be broken down is a pigment that is derived from hemoglobin, which is called bilirubin. So this causes an increase in bilirubin levels. The primary organ that deals with bilirubin is the liver. It actually produces bile. So it uses the bilirubin to produce bile. So the liver is going to break it down. So the liver breaks it down.
As in the fetal liver?
Yes, the fetal, well, the newborn's liver, right? If the liver cannot break it down fast enough, then we have a situation where the baby's going to start to turn yellow. And what is that called? Jaundice, right? So a buildup of bilirubin in the tissues causes jaundice. And that can be a problem if it's not dealt with, but it's kind of easily dealt with. And does anybody know how they typically deal with jaundice in newborns? They put them under lights. And so they use what are referred to as billy lights. But you can also, if you have a baby during a time of the year where you can just take them outside and put them in the sunshine, that works as well. So if it's like in the middle of the winter and you can't take your baby out and expose its skin to sunlight, then you use the billy lights. So if we look at, this would be a jaundice baby, right? So they have the yellow tint to them. Sometimes they also get yellow eyes, right? Sometimes you can see the yellowing on their gums. If it's really bad, their gums will turn yellow as well. And so this is kind of how I thought this was the cutest billy light, right? So you expose them to the lights, and the lights help to break that down in their skin, and then their bilirubin levels go back to normal.
Pretty common, isn't it?
Yeah. Yeah. But the reason is that they have to go from having all of that fetal hemoglobin to replacing it with the adult hemoglobin. And that's actually a gene regulation thing. One gene gets turned off and one gene gets turned on, and then they start to replace that hemoglobin. Interestingly, because these babies, the fetus does not have beta hemoglobin, they actually thought or are thinking about using this mechanism to treat sickle cell anemia. So maybe it'd be better for people with sickle cell anemia to have fetal hemoglobin than adult hemoglobin, because their adult hemoglobin is defective, but their fetal hemoglobin wouldn't be, because it's a separate gene that codes for a different part of the molecule.
Do you think that maybe if somehow they could get the fetal hemoglobin that the gene regulation would also turn that off? If they have to turn off the...
Yeah, so you have to turn off, unfortunately, it would be in the stem cells in the bone marrow.
Yeah.
So you have to figure out how to genetically modify all those stem cells so that they would turn off the beta one and keep the gamma one active. So that's kind of a engineering problem.
Because it's sickle cell, like if you're a female and you have sickle cell, what are the odds that it's going to be transported to your...
Well, in males and females, it's not sex linked. So males and females that give it equal probability, and it's 50% because generally it's carriers that are having children. And so if two carriers get together, it's 25% that their offspring would have sickle cell anemia. Okay, so we also need to talk about carbon dioxide transport, and this is a little bit more variable. So there's actually different ways that we can transport carbon dioxide in the body. And so one way to transport it is just it dissolved in the plasma. So the plasma is just the fluid besides the blood cells. So this would be outside of the blood cells, just in the plasma of the blood. And so they think about 7 to 10% of carbon dioxide is actually transported in this fashion. We can also have the CO2 can actually bind to the globin port of the hemoglobin molecule. So that's about 20%. So it doesn't compete for access to the same binding sites. It's a different binding site. Carbon dioxide binds to the proteins, not to the iron molecules. And then the third way is actually what is demonstrated below. It can be converted to a bicarbonate ion. Using an enzyme inside of the red blood cells. And so this is actually the chemical reaction that I showed here, where we have water, right? And carbon dioxide combines with water to produce carbonic acid, but then it can dissociate into bicarbonate ions and hydrogen ions. And so the bicarbonate ion would be HCO3 negative. So that's my bicarbonate ion. But the thing about that is that in order, it can be transported that way, but that's not the way that we breathe it out, right? It cannot diffuse out that way. So it actually has to be, if it is in a bicarbonate form, it has to go back into the CO2, so it's got to be converted back. So this chemical reaction has to go backwards to produce the gas that can actually diffuse across the plasma membranes of cells. So this would be about 70%. So most of it is converted to bicarbonate ions. This is actually really important chemical reaction, because when we get to the urinary system, we're going to be talking about the regulation of blood pH through the respiratory system, but also through the urinary system. And so you can notice here that CO2 can release hydrogen ions, but it can also go the other way. So this actually creates a buffer system in the blood that helps to maintain a relatively constant pH. So we'll talk about regulation of blood pH when we get to the urinary system and the kidneys. So you might have heard of the term perfusion. Does anybody guess or give me what they think might be the definition of this? Perfusion.
The exchange of oxygen.
It's good. That's a good. So oxygen that goes, or oxygenated blood that goes to the tissues, if that flow to the tissues is adequate, then we say that perfusion is good to the tissues, right? The tissues are perfused, right? So this is the flow of oxygenated blood into the tissues. Right? If that flow of oxygenated blood to the tissues isn't good enough, then we could have the tissues starting to die or atrophy or become diseased, right? So they don't. So this is just kind of a measure of the flow of the oxygenated blood to the tissues. And it's really important that when we're talking about tissues like the alveoli, that we want blood flow to the alveoli and the ventilation to kind of match. So we want in the lungs, the flow of blood, perfusion, and ventilation to match. So in the lungs, we want blood flowing to the alveoli to match the air coming in to the alveoli, and that is called ventilation. This is ventilation. So sometimes this does not happen if your lungs are damaged, right? So if we have a mismatch of perfusion and ventilation in damaged lungs, then you're not going to get adequate oxygenation of the blood. So mismatch of these in the diseased lungs leads to inadequate oxygenation of the blood. So that's the idea of perfusion and ventilation in the lungs matching. Okay, so the last thing we're going to talk about in terms of respiratory system are respiratory diseases and illnesses. And so one that we've kind of looked at already because it can be related to allergies is what is referred to as asthma. So this can be related to allergies because it can be caused by an allergic reaction, initial allergic reaction that then causes the constriction of the airways. So this is constriction of the bronchioles. The important thing about this is that a person will feel like they're not able to breathe in enough air. And they will also have a wheezing cough. So specifically a dry wheezing cough. So that is different from what we call bronchitis. So bronchitis is inflammation of the bronchi. And so this is characterized by a productive cough. And you have mucus buildup in the lungs. Mucus. This can actually be infectious, right? So it can be caused by a bacteria or bacterial or viral. So it's important to realize that just because you're coughing up substances might not mean that you need to go on antibiotics, right? Because it could be a viral bronchitis, which is different from the bacterial. So remember, antibiotics only work on bacteria. So oftentimes bronchitis might be treated with antibiotics unnecessarily. So how do they treat asthma? And what is that?
This one's gonna open up the area for the alveoli.
So it is actually a steroid. which decreases inflammation. So albuterol is a steroid that decreases inflammation. So it helps to open up those airways. It also causes a dilation of the airways. So it is not treated with antibiotics. This one can be treated with antibiotics if bacterial. Okay. So we can have acute bronchitis, which is due to just one infection, and it tends to be not long-term. But sometimes people get what is called chronic bronchitis. And chronic bronchitis tends to be people that are either smokers or people that are exposed to a lot of air pollution. And so they can get chronic problems, mucus, and then that leads to infection in their lungs. Okay. So the next disease is emphysema. And emphysema and bronchitis tend to go hand in hand. Specifically when you start to get a diseased lung in a person that is going to be chronic, long-term, and life-threatening. So emphysema is actually due to the destruction of alveoli. So those are the sacs where we have our respiratory membrane. And so what this causes is a decrease in the surface area over which gas exchange takes place. Right? So they just don't have enough surface area in their lungs. And so to compensate for that, remember, we give them gases with higher partial pressures of oxygen, and then that is going to speed up that rate of diffusion across the membrane. So these two combined, when you get this combined with this often leads to what is referred to as COPD. So this is chronic obstructive pulmonary disorder. And COPD can be a leading cause of death, probably most commonly caused by cigarette smoke. But I actually knew somebody who died from like 30 years ago, he died from inhaling chemicals from a factory that were making the mesh of lawn chairs. So they didn't have proper ventilation, and those chemicals just kind of destroyed his lungs and led to that chronic obstructive pulmonary disease. So I'm going to show you just a short video today, and this is how cigarettes affect the body. And so this not only talks about the lungs, but the other effects that smoking can have on the body.
Cigarettes aren't good for us. That's hardly news. We've known about the dangers of smoking for decades. But how exactly do cigarettes harm us? Let's look at what happens as their ingredients make their way through our bodies and how we benefit physically when we finally give up smoking. With each inhalation, smoke brings its more than 5,000 chemical substances into contact with the body's tissues. From the start, tar, a black resinous material, begins to coat the teeth and gums, damaging tooth enamel and eventually causing decay. Over time, smoke also damages nerve endings in the nose, causing loss of smell. Inside the airways and lungs, smoke increases the likelihood of infections, as well as chronic diseases like bronchitis and emphysema. It does this by damaging the cilia, tiny hair-like structures whose job it is to keep the airways clean. It then fills the alveoli, tiny air sacs that enable the exchange of oxygen and carbon dioxide between the lungs and blood. A toxic gas called carbon monoxide crosses that membrane into the blood, binding to hemoglobin and displacing the oxygen it would usually have transported around the body. That's one of the reasons smoking can lead to oxygen deprivation and shortness of breath. Within about 10 seconds, the bloodstream carries a stimulant called nicotine to the brain, triggering the release of dopamine and other neurotransmitters, including endorphins, that create the pleasurable sensations which make smoking highly addictive. Nicotine and other chemicals from the cigarette simultaneously cause constriction of blood vessels and damage their delicate endothelial lining, restricting blood flow. These vascular effects lead to thickening of blood vessel walls and enhance blood platelet stickiness, increasing the likelihood that clots will form and trigger heart attacks and strokes. Many of the chemicals inside cigarettes can trigger dangerous mutations in the body's DNA that make cancers form. Additionally, ingredients like arsenic and nickel may disrupt the process of DNA repair, thus compromising the body's ability to fight many cancers. In fact, about 1 of every 3 cancer deaths in the United States is caused by smoking. And it's not just lung cancer. Smoking can cause cancer in multiple tissues and organs, as well as damaged eyesight and weakened bones. It makes it harder for women to get pregnant, and in men, it can cause erectile dysfunction. But for those who quit smoking, there's a huge positive upside with almost immediate and long-lasting physical benefits. Just 20 minutes after a smoker's final cigarette, their heart rate and blood pressure begin to return to normal. After 12 hours, carbon monoxide levels stabilize, increasing the blood's oxygen carrying capacity. A day after ceasing, heart attack risk begins to decrease as blood pressure and heart rates normalize. After 2 days, the nerve endings responsible for smell and taste start to recover. Lungs become healthier after about 1 month, with less coughing and shortness of breath. The delicate, hair-like cilia in the airways and lungs start recovering within weeks and are restored after 9 months, improving resistance to infection. By the 1-year anniversary of quitting, heart disease risk plummets to half as blood vessel function improves. 5 years in, the chance of a clot forming dramatically declines, and the risk of stroke continues to reduce. After 10 years, the chances of developing fatal lung cancer go down by 50%, probably because the body's ability to repair DNA is once again restored. 15 years in, the likelihood of developing coronary heart disease is essentially the same as that of a non-smoker. There's no point pretending this is all easy to achieve. Quitting can lead to anxiety and depression resulting from nicotine withdrawal. But fortunately, such effects are usually temporary, and quitting is getting easier, thanks to a growing arsenal of tools. Nicotine replacement therapy through gum, skin patches, lozenges, and sprays may help wean smokers off cigarettes. They work by stimulating nicotine receptors in the brain, and thus preventing withdrawal symptoms without the addition of other harmful chemicals. Counseling and support groups, cognitive behavioral therapy, and moderate intensity exercise also help smokers stay cigarette-free. That's good news, since quitting puts you and your body on the path back to health. If you want to see more videos on building healthy habits, check out this playlist. And if you want to help support TED-Ed's non-profit mission, please consider making a small donation at patreon.com/TED-Ed.
Okay, so we'll stop there for today. You're going to end the digestive system next Monday. Yep.
They get to
Hematocrit is the percentage of your blood that is red blood cells. Okay, so you can have a lot of red blood cells, but you might not have enough hemoglobin. So it's the hemoglobin levels are related to red blood cells. Like the more red blood cells you have, the more hemoglobin. But you can be anemic, still have a lot of red blood cells, but if you don't have enough hemoglobin, that's the problem. Then you get, so that's the difference between those two. Yeah.
Is it 2:31?
It is not going to be in the spring.
Okay, so 2:30.
Yeah,
Okay,
yeah.
but 2:32, everyone's spring.
So I do 2:33, yeah, so I do 2:32 in the spring.
Okay.
So you could switch to Kristen, but you would have to wait till fall. I'll take 2:31.
Okay.
So it's a few. Okay.
I
I
recommend
it. Oh my gosh.
Yeah, okay.
Thank you.
Yep.
I can't go.
Were you supposed to?
Yeah. I told her to like this is to schedule more times.
I'm looking for the night shifts. Saturday, or no, Friday. Oh,